Good morning and welcome to the 15th meeting of the Health and Sport Committee in 2020. The first item on our agenda is an evidence session on the impact of COVID-19 in care homes. To inform this session, we invited evidence from care home staff, residents, families, owners and managers, and we are grateful for all submissions. A number of respondents asked us to keep their submissions confidential, and in order to get as much evidence as possible, we have chosen not to make submissions public. We want all concerned to feel that they can tell us what they know without fear of adverse consequences. While our usual approach to written evidence is to make it public, we recognise in the current circumstances that we need to offer those in the front line some additional protection so that we can hear from as many people as possible. All members of the committee have access to all submissions. They help to inform our work in scrutinising the government's response to the pandemic. And of course, anyone who has made a submission to the committee is free to make it public on their own behalf. To address this issue, I welcome to the committee Jean Freeman, Cabinet Secretary for Health and Sport, accompanied by Professor Fiona McQueen, Chief Nursing Officer, and Donna Bell, Director for Mental Health and Social Care. Thank you for joining us today. In a moment, I will invite the Cabinet Secretary to make a short opening statement of up to 5 minutes. Due to the challenges of managing a virtual meeting such as this, we will again take questions in a pre-arranged order. After the Cabinet Secretary's opening remarks, I will start with the first question, invite the Cabinet Secretary to respond, and then take each member in the order we have agreed. Once each member has exhausted their questions, I will ask the next questioner to put theirs. It's helpful to broadcasters if you're able to stay when you're on your final question. I would ask that all questions and answers be kept as succinct as possible. And please give broadcasting staff a few seconds to operate your microphone before beginning to ask your question or provide an answer. Thank you very much. And now I invite Jean Freeman, Cabinet Secretary, to make an opening statement of up to 5 minutes. Jean Freeman.
Thank you very much, Convener, and thank you to you and the committee members for the opportunity to be here with you this morning and to answer your questions. I am conscious of time, so I will be very brief. I'm sure there are a number of questions. I think it is important for me to say from the outset that both I and Scottish Government have been clear on the importance of taking steps with respect to both care at home and care homes. That's why we issued guidance to care homes on the 13th of March, guidance that we have regularly updated since that time, most recently on the 4th of May. We intervened to provide direct PPE provision from the 19th of March when it was clear and we were informed that the previous private PPE routes to care homes were falling. To date, more than 53 million items of PPE have been distributed from national NHS stock to over 1,000 locations across Scotland, and on the 2nd of April we issued PPE guidance for health and social care settings. The first set of clinical and practice guidance was issued to care homes on the 13th of March and regularly updated since. Guidance issued to GPs on the 17th of April in terms of ensuring that their role with respect to care homes was being enacted and checking that they didn't need anything more from us. And of course, on the 20th of April, we tasked Directors of Public Health with taking enhanced clinical leadership for care homes. The recruitment portal to ensure that care homes could access staff where staff absence rates meant that their rotas were at risk. That recruitment portal through the SSSC went live on the 29th of March. Members will recall that that is NHS and social care returners who had volunteered to come back and be employed in both the health service and in social care over the period of the pandemic. And on the 12th of April, I did make that additional announcement of the 3.3% uplift for adult social care providers payable from the 1st of April. And on the 24th of May, confirmed enhanced sick pay arrangements and the death in service payments from government for those social care workers, care home workers whose employer terms and conditions were such that it was causing those individuals significant personal dilemmas in terms of being tested if they tested positive, when they would see their income severely reduced. And members will be aware of the testing regimes introduced from the 15th of April right through. So we have followed the best advice and taken the judgments that we believe to be correct from the outset of this pandemic. There is undoubtedly lessons for us to learn and more work for us to do, but it is worth, in concluding, just reminding members that 38% of adult care homes have lodged no notification of suspected COVID-19 incidents to the Care Inspectorate since the start of the epidemic, and 58% of adult care homes have not registered cases of suspected COVID-19 in the last 14 days. With that, Convener, I'm happy to stop at that point and begin to take the questions from you and colleagues.
Thank you very much, Cabinet Secretary. We put out a call for evidence. We put out 2 calls for evidence. One of those was specifically directed towards owners and managers of care homes. Many did respond, and every single one of them told us that they had begun instituting measures to protect residents before the lockdown was announced on the 23rd of March, either in February or in the first fortnight in March. What, in your view, is the reason, given the alertness of care home managers and these measures being put in place, what is your view as to why COVID has affected, as you say, something in the order of 40% of care homes in Scotland?
So I think that at this point it's not possible to reach a definitive view. I think that only comes as we gather all the evidence and all the data over time. It's certainly the case that prior to the pandemic, all care homes would be expected to abide by the standard infection control prevention and control manual, and it would be against that pre-pandemic care homes would be inspected by the Care Inspectorate. So infection prevention and control should not be new to care homes. Clearly, many felt better prepared to enhance those measures. Many may have felt that was more a normal part of their regime than others. Our guidance on the 13th of March, though, was very clear that we asked at that point for care homes to undertake screening for symptoms as part of HPS guidance, that transitions from hospital should be screened clinically to ensure that people were not transferred inappropriately, that communal activity and physical distancing communal activity should be reduced by 75% at that point, with residents remaining in their rooms as much as possible. And as members know, essential visitors only were allowed, with the particular exemptions about end-of-life care and residents who were experiencing dementia. And also, of course, the clear guidance on the use of PPE. So I think it is difficult at this point to say why some care homes have not experienced any cases at all and others have. I think that we can understand why if 1 or 2 cases begin, the risk of transmission to other residents is high in certain circumstances. But I also think that what appears to be emerging from some of the evidence, but is by no means complete at this point, is that there does appear to be a distinction between the sizes of care homes, with care homes of a smaller size, 30 beds and under, appearing to do better in terms of handling this virus and the incidence of it than others. But as I say, that has to be heavily caveated as only early emerging information that appears to suggest that.
Presumably, clinical screening of patients being discharged from hospital to a care home, either as new or as returning residents, presumably that clinical screening would have been done at the hospital end. Can you remind us of the final tally of the numbers of patients who were discharged to care homes in those circumstances, and what advice was given to the care homes about preparation for ensuring the safety and health of returning or new residents, and in particular the issue around COVID testing of patients discharged in those circumstances?
Yeah, so well, actually, no. The clinical assessment about assessing the clinical appropriateness of discharge is an exercise that should be undertaken both in the hospital setting and with the setting where the patient is being discharged to, in order to ensure that the receiver of the individual, whether they're returning to the care home or whether they are entering the care home for the first time. And remember that many discharges to care homes are for intermediate short periods only, whilst, for example, care packages are put in place in their own home. But those clinical assessments should be undertaken at both places in order to, for the receiving destination, if you like, to know what the individual's physical condition is and what medication and so on, other health support they might need before they are discharged. And the advice was clear in terms of isolating people in their rooms. Of course, we're talking about people who are clinically able to be discharged. In other words, the reason for which they were in hospital in the first place has been addressed and they no longer require treatment that only the hospital can provide. So that is the first position in terms of discharge. The assessment is done, should be done by both parties. And so when an individual is admitted to a care home from a hospital, the care home knows what their overall health condition is, what their medication needs are. And of course, many of our care homes employ nursing staff in order to assist. The care home should know who the local GP is to provide ongoing care and so on. And the advice on isolation was clear.
But to be clear, those assessments at both ends of the discharge process did not automatically include testing for COVID-19?
Not in that early period, no, they did not.
What preparations should care homes make in the current circumstances where lockdown restrictions are being eased? What additional preparations would you expect them to be making now, and what guidance will be provided? I asked that question in the context that care homes have told us that one of the things they struggled with is the multitude of guidance issued, but bearing that in mind, what additional or what clarification will you provide to care homes going forward?
Well, in terms of the current easing of lockdown measures for the general population, there is no direct impact in terms of the guidance that is offered to care homes. They should continue to be following the most up-to-date guidance, so they should be expecting that any admission from hospital of someone who has been in hospital for COVID reasons, that there should be 2 negative tests, and the care home should be assured of that before accepting the individual. The clinical assessment should still continue, notwithstanding testing. Someone who has been in hospital, excuse me, for a non-COVID reason should have 1 negative test before admission, and this similarly applies to community admissions. And in both those cases, then there is an isolation requirement as well for that incubation period, if you like, to ensure that despite the negative test, the individual is still given a period where they are isolated and supported in their own room in order to ensure that symptoms of COVID do not emerge. Because as we know, the test tells you whether you are positive or negative on the day that the test is taken. It doesn't give you a long-term negative result, simply a result on the day the test is taken. We continue to supply PPE to care homes. We have undertaken direct deliveries, but I understand from Scottish Care that the hub route is working effectively. Of course, if any issues are raised with us, then we address those. As you know, in Highland, NHS staff are supporting a particular care home that is supported elsewhere, as well as that portal that I described, so that we can ensure that where staff are absent and rotas are compromised, then additional staffing and support can be offered. The Care Inspectorate is in daily contact with many care homes, definitely weekly contact with all care homes in order to ensure that they have the support and any clarification on advice that might be needed. And then, of course, there is our enhanced clinical work through directors of public health, also in contact with care homes in their board area. And now the testing regime that you're aware of testing of residents and staff in care homes with a single case, then testing of all, and testing of care workers in homes where there is no case.
You mentioned a possible emerging pattern of smaller care homes having perhaps coped better. Are there any other, I know it's preliminary, but are there any other lessons you may draw from those care homes which have not had cases of COVID-19 in the last few weeks?
It seems primarily it is an indicator of size. There is, to my knowledge, although the Care Inspectorate is looking at this for us, whether there is any connection between the assessments from previous care inspections by the Care Inspectorate and how homes have coped with the current situation, but they have not concluded that piece of work, so I don't know, but it is something that we have asked them to do to try and understand why, as I've said, that 38% of homes have not had a single case and what might be the issue. We do understand that some care homes have taken additional precautions in terms of their own staff, where staff have stayed in the care home. That is a significant ask of staff. But again, it's not clear yet. The data that I have isn't clear yet whether that correlates directly with that 38% that I mentioned.
Thank you very much. I now call Brian Whittle.
Thank you, Convener. Good morning to the Cabinet Secretary. I'm going to ask questions around guidance. I think the guidance was fairly clear that the care sector was key in freeing up capacity in hospitals. And we know that was over 1,000 patients were discharged into care homes to help that capacity within hospitals. So can I ask to start off with what early preparations were made, I'm saying before March, for example, were undertaken by the Scottish Government to protect residents of care homes and the staff working in them? And Cabinet Secretary, do you think enough was done early on?
Cabinet Secretary.
So the early work that was done with care homes was, as I've said, all care homes should be following the Infection Prevention and Control Manual. That forms part of the basis on which they are inspected. And early discussions with Scottish Care around preparedness and what might be needed, of course, were held. As Mr. Whittle knows, I discuss regularly with Scottish Care what the issues are that are coming through to them from their members, and they have an engagement with many of the officials in the Health Directorate as well as with local health and social care partnerships. Health and social care partnerships were actively engaged in considering what might be possible in terms of their own mobilisation plans and were aware that where there was additional cost requirements, including from care homes, on top of the money that was already allocated through the 2021 budget, then Scottish Government would meet those additional costs. We've already made some initial funding allocations out to the sector, but there may well be more that is needed on top of that. So there were early discussions around the preparation, around understanding the importance of infection prevention and control, And as I said, making sure in terms of that 13th of March guidance that it was clear about the requirement for that shared clinical assessment before discharge. The numbers are, as Mr. Whittle has quoted. Interestingly, though, or importantly, the numbers for April are reduced, and in fact for April this year are lower than the discharges to care homes for April 2019. And of course, we are now in a different situation in terms of the testing regime that is required.
Brian Whittle.
Thank you. One of the things that when we were gathering evidence, they said that the new guidance was issued frequently, sometimes with just some minor changes, and they said that, and you find that you're required to read the same document numerous times to find small amendments. So why have there been so many revisions to the guidance for care homes? I think there's been 4, for example, since just the end of April.
Cabinet Secretary.
So in terms of the guidance that is issued by government, if you like, there was the 13th of March, 26th of March, and then the 15th of May. Health Protection Scotland do issue additional guidance for particular purposes and do review and update those. Some of those updates, as Mr. Whittle says, may be relatively minor in order to align their previous guidance with guidance that government has issued. I wouldn't demur from the comments that have been made about, I think it's less about too much guidance and more about requiring a degree of effort to navigate your way through all the guidance. That's a clear lesson, I think, for all of us about streamlining this and making it as easy as possible for people to follow what is the most up-to-date guidance, and if it is revised, making it very clear to people the bits that have been revised so they don't have to read the whole thing to find where the changes are. And I think that is an entirely reasonable point for the sector to make to me and through me to HPS, and one that we will take on board and try and ensure that we provide as much clarity as we can about what is the guidance that people should be finding, and making it easier for them to understand the guidance that they should be working to.
Brian Whittle.
Of course, in that, convener, in that some of that we're very well aided by the work of Scottish Care, and they have made this point to me in the recent period.
Thank you very much. Brian Whittle.
Thank you. I think with that in mind, I think one of the things that been the evidence gathering suggested that there's a lack of clarity around the government advice, and also it is coming from the local health and social care partnership, it's coming from Health Protection Scotland and the NHS. In the case, Cabinet Secretary, for a single body to be responsible for providing the care sector with appropriate and informed public health guidance.
Cabinet Secretary.
So there may be a case for that. Certainly the guidance that should be being issued in the current circumstance is from government, that clinical and practice guidance that's signed off, cleared, if you like, from our Chief Nursing Officer and our Chief Medical Officer, and then by me before it is published. And of course, HPS, in their very particular role, issue guidance. I am aware that there have been at least one instance, there may be more, that I am aware of, where it appears that additional guidance issued by the local health and social care partnership did not help to clarify matters for individuals and created a degree of confusion. I remain unclear why a health and social care partnership should feel the need to issue anything, but should not just be working as I would expect them to from the guidance issued from our senior medical and clinical advisors in government and also from HPS. It may be, convener, I don't know, but we have Professor McQueen, of course, our Chief Nursing Officer, with us this morning, and it may be she wants to say a little bit more on this whole question of guidance and clarity around guidance.
Fiona McQueen.
I think, as the Cabinet Secretary said, the issue of Health Protection Scotland and providing guidance on infection prevention and control, and also on the personal protective equipment, so to keeping our residents and our staff safe. I think we absolutely agree that if our care homes are saying it's complex and too demanding, then the feedback we've had is that we want to try and streamline that. However, what we can't do is hold back information or guidance if we think it's going to be to the benefit of the residents, and therefore the issuing of and reissuing of guidance would be for that very purpose. I think what we now have put in place in terms of the more clinical oversight is making sure that we're having daily contact with care homes and asking them questions in a supportive way to make sure that they know and understand if there are residents they're worried about, or if there's any staffing issue or any issue with personal protective equipment, or how they should be supporting the residents, then that dialogue is going to be much better than in issuing anything from the Health and Social Care Partnership. So we're trying very hard to wrap around care homes, give them support, as well as having the guidance from Health Protection Scotland that is developed by infection prevention and control experts, and changing as the knowledge of this virus changes quite frequently. Then it's important that we do update the guidance and help and support care homes to understand the very practical implications of what they can do at all times to keep the residents as safe as they can.
Thank you very much, Brian Whittle.
Thank you, Camilla. Finally, can I ask, it's around the submission that suggests that the guidance assumes that care homes are equivalent to hospitals in terms of accommodation, and that they can move people beds around at will, and their suggestion is that is not true. So can I ask how the care sector was involved in discussions about what guidance was required, and going forward, Cabinet Secretary, how will you liaise with the care home sector in anticipation of potential further outbreaks of the pandemic?
Cabinet Secretary.
So there is a difficult balance to strike, which we've touched upon before in these conversations, either with yourselves as committee or, excuse me, elsewhere in the chamber, and that is the balance between ensuring that the right clinical procedures and protections and preventions are put in place in the care home setting, whilst also trying to recognise that is people's home. And that can jar at times, and it's certainly true that Donald McCaskill from Scottish Care and I have discussed the difficulty around getting that balance right on a number of occasions. And I don't think either he or I would claim at any point that we have got to a place where the balance is right. Clearly, the absolute focus at the moment is on the right clinical and medical support in order to prevent the introduction of the virus into care homes as best we can, and the transmission of the virus inside the care home. That goes all the way through from that guidance on the 13th of March. But that can be a difficult situation for residents in a care home who, from the 13th of March, we have said, should be spending most of their time in their own room. And so much of the activity and the social engagement that they have used to, that means that their time in this homely setting is as stimulating and enjoyable and safe as it can be. Some of the stimulating and enjoyable elements have been sacrificed in order to ensure safe. And that is particularly difficult for individuals who suffer from dementia, but difficult for all because, again, family members, friends have not been able to visit. I am supremely conscious of that, and will want, as we make progress, to see whether or not any of that can be eased in any respect. because there are impacts here, just as there are health impacts for the rest of the population on what we have asked people to do, particularly for the group who are shielding. Then there are impacts here, I know, for residents of care homes in terms of their own well-being. So as we learn lessons from all of this, that will be central to how we go forward. I'm not sure that we will ever successfully balance the homely setting with the need for measures to address a virus that has the capacity to have such devastating impact on individuals, particularly elderly and frail residents. But care homes are not new to the idea of dealing with infection. So we have flu every year, we have winter vomiting and other infections. So there are clearly lessons to learn from this period, albeit we're not past the pandemic at all, but there are lessons to learn that we should be and will be discussing with them about how influenza and other infections are handled, particularly as we approach the winter period.
Thank you very much. I now call David Stewart.
Thank you, Convener, and good morning to the Cabinet Secretary, and also good morning to Donna Bell and Professor McQueen. Could I build on, Cabinet Secretary, your answers to my colleague Brian Whittle? If I could just summarise very quickly 3 quick points from the submission. You've already touched on this earlier. The first of all, that care homes are obviously not hospitals. Secondly, that separation of residence is not always available to care homes. And finally, with severe dementia, isolation and containment while respecting human rights is challenging. Would you reconsider the guidance to care homes to take into account the above comments that I've just made?
Cabinet Secretary.
Thanks very much, and good morning to you too, Mr. Stewart. If you mean the guidance in the current situation where we are dealing with the coronavirus pandemic, I think not to any great extent. We may want to ask my colleague Donna Bell in terms of the dementia work, whether or not the consideration we're giving at this point as to whether or not there is more advice we can offer care homes about those residents who experience dementia, for whom staying in their own room for significant periods of time is simply adding to their distress and their anxiety, not least because their cognitive capacity to understand why that is the case is in many instances diminished. Whether or not we can ease that by giving guidance on other mitigating measures that care home staff could take to support more time by individuals out of their own bedroom. I'm very conscious of the issue around human rights and people's rights in this matter. And you would, as I'm sure it would be no surprise to you, that my colleague Ms McKelvey is also very actively concerned about this, and we are due to have some further discussion on that. And it always is the balance between what is it that you need to do to protect an individual from a health harm that is significant and immediate and has clearly the capacity to cause death, and the balance between that and other potential health harms that arise as a consequence of what you do to deal with the first one. So I don't have any straightforward answers for you, I'm afraid, Mr. Stewart. I can assure you I'm very conscious of the dilemma. It's a very real and pressing one. There are some areas we're looking at, and we may want to hear a word or two from Ms Bell, particularly around the area of dementia, and indeed from Professor McQueen, who in terms of whether we do anything on that, would be very engaged in what the mitigating measures might be that you would take to protect residents and staff in that situation.
That's helpful, Cabinet Secretary. I'll call David Stewart again, but bear in mind that if we have time, we can hear from the other witnesses also. David Stewart.
Thank you, Convener. And my final question, Cabinet Secretary. I was looking at some statistics earlier this morning, which was helpfully put out in the Preston Journal, which showed that from April the 20th, deaths from COVID-19 have been higher in care homes than in hospitals. What plans are there to beef up the resources and powers of the Care Inspectorate to, first of all, identify residents across Scotland who are particularly at risk, and service providers who fail to meet requirements for improving a service? I do understand that they have got some rights and responsibilities currently. My point is, can we beef up the Inspectorate? Very much my argument is, who is guarding the guards currently?
Cabinet Secretary.
Thanks very much. And those numbers, I think, that you referred to, Mr. Stewart, come from the NRS publication yesterday. And of course, NRS, as with other areas, are looking to publish as much data once they're confident it is robust as they possibly can. And the figures published yesterday did indeed show that the incidence of death in care homes is now higher than in hospital. In terms of the Inspectorate, so the Care Inspectorate does have a number of important powers. I think we probably are seeing them exercise those with respect to Home Farm care home in Skye, where they have taken a very serious step indeed of applying to the court to have that owner of that care home deregistered. The court will reach a view later on this month. I had a call with the Care Inspectorate towards the end of last week, where we discussed a number of the on-site inspections that they are currently doing. From memory, 27 on-site inspections in the last 2 to 3 weeks of 19 establishments. So that is where they are doing on-site inspections, but they then return to the place they inspected first, because they have required them to make improvements. They go back to see if those improvements are made. And of course, if those improvements are not made and the Inspectorate considers those to be serious enough in terms of the safety and well-being of residents, then they can take further steps. But that does not rule out the Care Inspectorate having more powers than they currently have. I'm very happy to look at that in the round as we look at, and take the Care Inspectorate's view as well, of course, as we look at what lessons we are learning. There's, if you like, an immediate set of lessons to learn, so we prepare for the continued presence of the virus, and also prepare now for the coming of winter, where we will expect more respiratory infections and so on to appear as they normally do. And then there's the longer term view about the whole landscape of care in care homes and in the community.
Thank you very much. I now call David Torrance.
Thank you, Convener. Good morning, Cabinet Secretary. And my questions are around primary care support. A number of care homes says that GPs had not come into care homes to diagnose or treat patients, regardless of COVID-19 status, meaning that managers were having to manage symptoms themselves. Can the Cabinet Secretary tell me when it was clear advice sent to GPs about visiting care homes and treating non-COVID-19 residents?
Cabinet Secretary.
So care homes, so primary care and GP practices all have connections with the care homes. And in the circumstance of the pandemic, GP practices, not all, but many, took the view that they would, as far as was, in their view, clinically correct, deal with their patients in care homes as they were dealing with patients elsewhere, and that was a lot by way of digital technology and telephone discussion with care home staff. That hasn't precluded GPs in many instances visiting care homes in order to see residents about other health concerns that they may have. We have, of course, as you know, took steps very early on to ensure that our GP practices had the delivery and the stock of PPE that they needed, as they would need, for example, to undertake those visits. So my overall response is that I am not aware of circumstances where GPs have refused to visit care homes if that was required, but they have mixed their care for patients in care homes between the use of
seem to have a momentary delay in receiving from the Cabinet Secretary. I wonder if I could take the moment to ask Donna Bell to comment on the dementia care guidance, which I think issued only on the 22nd of May, but to ask how far the care home sector was consulted in producing that guidance. Donna Bell.
Thank you. Yes. So the dementia guidance produced has, I think, been widely consulted upon. And I think the Cabinet Secretary outlined very well the balance that needs to be struck from minimising distress to residents and keeping them safe. We're very aware of that balance. There is a lot of work underway already in care settings to manage that. And making sure the right mitigating measures are in place around social distancing and cleaning, etc. There is further work underway at the moment, and that will include engagement with a range of partners, including experts in the world of dementia, along with a range of people who work in those settings, to set out how we will manage this through the next phase and phases of the route map. I think at all times we must keep in mind the balance, though, to make sure that we are minimising distress, but at the same time really keeping the residents safe. My colleague Fiona might want to come in here. She probably has more direct experience of what is going on in these settings at the moment.
Fiona McQueen.
I mean, clearly, many residents in care homes have dementia, and our care home staff are very experienced in caring for older people with dementia. And the advice and guidance was to isolate, but clearly the individual judgment of the healthcare worker would be put in place for that. And where there was such distress, then although we've said no visiting, where there has been real distress of residents, then we would expect families to be able to come in and support them. But also we would expect the care home to be able to respond to that. So perhaps within a room, more activities, more therapy for that person to be able to keep them occupied, keep them settled. And where a resident is better to wander, then clearly from a human rights point of view, it would be fair and reasonable that that happens. And again, that would mean from a staffing perspective, that person being accompanied so that they can be guided and supported, but also additional cleaning, because if older people perhaps wander around a care home, they're going to be touching surfaces, they're going to be using the handrails, and therefore the care home will be well used to looking at additional cleaning regimes that need to be put in place when there is an infection outbreak within the home and people are being cared for in that way. I think another aspect that people do find distressing is where there is infection within a care home, and in particular for people with dementia who don't understand why perhaps their ornaments and their knickknacks and reminders of their previous life perhaps are taken away so that there can be increased cleaning and there is a reduced risk of passing on infection. And we know that that's difficult, but I have every confidence that the staff within care homes are used to supporting their residents in that sensitive way and making sure there is a balance of providing the individual pieces of ornaments or furniture that helps residents feel safe and soothed and comforted.
That's helpful to understand. The evidence that David Stewart referred to was around the question of creating a homely setting for residents, and recognising that perhaps some of the guidance which might have been relevant to hospitals is less relevant in the context of care homes. I wonder, Fiona McQueen, if you could say a little more about what might be done to create that homely setting, or to acknowledge the concern that's been raised with us by many on care home management side, that it's very difficult to get that balance right. Is there any adjustment you might anticipate making in order to achieve that? Fiona McQueen.
Absolutely. We need to work with our colleagues within the care home sector so that we can find that best balance. And in some of the guidance where we talk about people who have infections, and in this case COVID-19, then we know that to minimise the spread of infection, if we can group together the residents who have that infection and group together staff then who would care for them, so staff aren't going from caring for people with COVID-19 to caring for people without. Although with good personal protective equipment that should not be a problem, but we know from a transmission-based precaution and infection prevention and control point of view, if we have the people with the infection in one area then and cared for by staff, the same staff, then we know that reduces the transmission of the infection. Now, in a hospital, you'll see that if there's winter vomiting, then you'll find that maybe 4 patients with winter vomiting are in the one room, and they'll be moved from room to room within the hospital. In the care home, then the residents have their own room. As I've implied earlier, they obviously have their own furniture, their ornaments, perhaps shawls or reminders of their past life, or pieces of equipment that give them comfort. And they've perhaps been in that room for a year. So the suggestion that we group together residents who have COVID-19 onto, say, one floor or another floor means that you would have to take the decision to move that resident from one floor to another floor. And that is incredibly difficult. The reason for doing that would be to protect other residents from being infected, and therefore you're asking one resident who is already infected to be disrupted from their room and moved to protect other residents. That's incredibly hard, and therefore I think there are other interventions you can do, so additional staffing, other additional cleaning, that we can make sure that it is as easy as possible for the social care staff to care for the residents in a way that stops the transmission within the care home, but keeps the residents safe. And that's a tension, because we see the public anxiety and about the deaths in care homes and the infections in care homes. But we also, on the other side of that coin, we see the public anxiety, and in particular the families' anxiety of not being able to be with their loved ones. And it's almost an impossible decision, and we need to apply that to each individual resident. And it's absolutely something we would be looking forward to working with Scottish Care and the wider sector with advice from the specialists in dementia.
Thank you very much. Can I go back to David Torrance?
Thank you, Convener. Cabinet Secretary, if GPs are not visiting care homes, is it safe for care home managers to be carrying out clinical procedures?
Cabinet Secretary.
I should say that the guidance to care homes on the 17th of April, which is where I'd got to, my apologies for disappearing on you there. We're now operating with a different device, but the guidance to care homes that was issued on the 17th of April was guidance from the Chief Medical Officer, and there of course have been subsequent engagement with GPs from the BMA and the Royal College of General Practitioners and the Chief Medical Officer around care and support for residents in care homes. In terms of whether or not managers carrying out clinical procedures, as I said earlier, very many care homes employ nursing staff who would have clearly the skills to carry out clinical procedures in certain circumstances, but care homes should expect, where that is not possible, that they receive the right level of care from their local primary care practice. As I've said, residents in care homes are in their home, and just as you would expect living in your own home elsewhere, that you would get that primary care and support from the GP or others in the primary care practice, then residents in care homes should expect that too.
Thank you very much. David Torrance, did you have a further question?
Oh, thank you, Convener. That's me finished.
Thank you very much. George Adam.
Thank you, Convener, and good morning, Cabinet Secretary. I'd like to ask a question with regards to PPE, because some of our evidence we received was care home managers expressed some desperation about their attempts to source PPE to protect their staff and residents, and that's understandable in what they're trying to do. And please correct me if I'm wrong here, Cabinet Secretary, in many cases, some of these homes are either private care homes or they are run by other organisations. So surely, if I was running a care home, it would be my responsibility to ensure that the company has the proper level of PPE and other equipment that they need.
Cabinet Secretary.
So I think that's a very fair point from Mr. Adam. I mean, at the outset of all of this, we understood that care homes may have to source additional volume of PPE, and we undertook to ensure that we could make provision from the NHS stock to support that. But as we know, in the context of a global pandemic with huge global demand for items of PPE, number of the privately sourced routes of PPE failed to deliver what the care homes needed and what our guidance said should be there for staff in terms of the use of PPE, both single use and otherwise. And so we stepped in and remain in that area. We stepped in to ensure that all care homes had the level of PPE that they need. That involved us increasing our orders, increasing the volume of our orders, and NSS, and I think it's appropriate to thank them here on the record for the way in which they stepped up to ensure that a sector that they had never previously been required to supply, that they did that in very short order, not only by direct delivery to individual care homes, but also through the local hubs, which again, with health and social care partnerships, were set up very quickly by them in order to ensure PPE availability to care homes, and now, of course, to unpaid carers and personal assistants. All of that in addition to the work that NSS undertook to provide direct routes of ordering and delivery to primary care sector, as I've mentioned before, pharmacy and so on, as well as, of course, the hospital setting. So Mr. Adams' point is a fair point, but I think our position was that we could not leave the provision of PPE to the vagaries of the marketplace, and had to make sure that we could use the expertise and the stockpiles that we had and the capacity to order in volume and track orders and be assured of quality through NSS to make sure that residents and staff in care homes had the personal protective equipment that they needed.
Thank you very much, Cabinet Secretary. George Adam.
Okay, Cabinet Secretary, if obviously we've had yourselves helping out the care homes in this situation, but if we end up in a situation where this spikes again, is there adequate supply, or do we have access to adequate supply this time? And sorry to labour the point, because I know you mentioned that privately sourced routes weren't available to them. Some other care homes actually said that they cited that the charge was very high for the price of PPE, the market being the way the market is when they need it. But surely, again, I'm labouring the point, we have to be in a position to actually be able to, as a business or as an organisation, they would have to know that they could get access to these type of things themselves.
Cabinet Secretary.
So in as much as care homes, indeed I've heard one provider describe it as an industry, it's not a term I would use, but in as much as the vast majority of our care homes are private sector provided, then obviously running a business, as in any business, you have overheads that you need to meet, and that includes your consumables, of which PPE, if we go right back to that infection prevention and control manual that predates this pandemic, should be what care homes were following in normal circumstances, then that would tell you that you need to have PPE. And so my anticipation is that the care home sector have a view of what government has done in order to ensure they have PPE as a temporary measure, and that they will be taking steps in normal course to ensure that their own supply routes stand up, and of course where that does not look to them to be something that is that they can rely on, or will give them the volume that they need, then we will continue to top up what they need in order to ensure that they have all the PPE that is required to undertake the level of infection prevention and control that is needed. It is the case, I think this has diminished a little, but it is the case that we saw some supplies of PPE where the prices were hiked considerably because of the level of global demand. And of course, NHS in Scotland has long had that procurement operation for very many years, with a significant degree of expertise in there to negotiate reasonable deals, good relationships with suppliers, and we have benefited without doubt from the intervention and role of my colleague Ivan McKee, where we now have used a difficult situation to create opportunities for Scottish companies to increase the number of jobs that they offer and begin to domestically supply items of PPE. That is a source of considerable progress, particularly as we look at the likelihood of ongoing demand that we will have for PPE and the continued variability of global supply chains.
Thank you very much. I'll call George Adam for a final question, and then I may suspend briefly in order to allow restoration of the picture as well as the sound. George Adam. Okay, thank you very much, Convener. Finally, I just want to ask Cabinet Secretary, when we look at how the care sector has dealt with this situation with PPE and struggled to a certain degree, do we need to possibly look at another model of delivery for the care home sector in the future, and how would we go about that? Cabinet Secretary.
So I think I said possibly a couple of weeks ago that I thought that it was an entirely legitimate debate to have in due course around the landscape of social care, both the care home sector and social care, and whether or not as a country we wanted to improve that landscape, and if we did, in what ways might we do that. I think that's entirely appropriate. Scottish Government has intervened also in people's terms and conditions where their contracted terms and conditions in respect of SSP, statutory sick pay and death in service has not been adequate, certainly not to the Fair Work principles that we uphold and that we have reached an agreement with the STUC. So there is a debate to be had, a discussion to be had about how social care looks in the medium to long term, how it is funded, how it is regulated, and how it is provided. And I think that is entirely appropriate. My focus at the moment, of course, as you would expect it to be, is on what we need to do now and in the weeks and months ahead to continue to provide as much protection and support to the care home sector and its residents and staff as we possibly can, and to, of course, care at home, working in partnership with our colleagues in COSLA. But I think that we would want to take early steps to begin to have that conversation, if you like, with all the interested parties, including the Scottish public, about what their views are on the provision of social care in Scotland.
Thank you very much, Cabinet Secretary. I'm conscious that it's important to see as well as hear you if we possibly can. So in order to deal with the immediate technical challenge, I will now suspend this meeting for a few minutes to allow the video link to be restored. Thank you very much. I now suspend this meeting. Thank you very much. I now resume this meeting. Thanks to everyone for your forbearance, and apologies to those watching the live stream that we did lose the Cabinet Secretary's picture for some time, but not her words, which of course is what we're here to deal with in particular. But thank you all for your forbearance, and I now move on to call Miles Briggs for the next question. Miles Briggs.
Thank you, Convener. I'm not sure if I'm sending video or not now, but I will press ahead. I wanted to ask specifically the Cabinet Secretary with regards to what the First Minister and the Cabinet Secretary said at the beginning of the crisis with regards to patients being moved from hospitals to care homes. So can the Cabinet Secretary outline the process behind the decision to transfer people and delayed discharge people from hospital to care homes, given the evidence we knew from across both Italy and Spain at the time?
Cabinet Secretary.
So, thank you very much to Mr. Briggs for his question. I need to go back to the 3rd of March and the statement I made in Parliament, where I outlined what at that point was the advice in terms of the likely worst case scenario of the impact of the virus on 80% of the population, 4% of that number requiring hospitalisation. I think from memory, 1%, I'll correct that if I'm wrong, requiring intensive care treatment. And at that point, we talked about what we had to do in order to ensure that our NHS in Scotland was able to cope with that volume of demand, if that is what should transpire. And at that time, and I think again on the 10th of March, my statement also then talked about working to reduce the numbers of delayed discharge, a long area of discussion pre-pandemic, of course, in the Parliament. But certainly on the 3rd and then on the 10th, there was no opposition from any of the parties to what we were aiming to do. And delayed discharge and discharging people, of course, from hospital isn't exclusive to care homes. And it remains the case that very many people discharge from hospital, elderly individuals, the folks that we are talking about, are discharged home with the appropriate social care package. And as I said, many are discharged to care homes for a short-term period only as a kind of intermediate step. But that was the approach that was taken. The guidance that was issued is as I've described, about proper clinical assessments. And I do need to make the point as well, of course, that all our guidance on these matters has complied with the World Health Organization's guidance too. So that was the approach that was taken. there was a presumption, which I think was a reasonable presumption, given the importance of the Infection Prevention and Control Manual to care homes pre-COVID-19, that infection prevention and control measures would be in place in care homes, but certainly the shared clinical assessment that was required in the 13th of March guidance, and has always been required, would highlight any issues where a care home felt unable to take an admission. Perhaps, for example, they would find it difficult to isolate the individual in their room as was being required.
Thank you very much. I'll remind members and indeed the Cabinet Secretary that we have lost a little time, and so I would encourage brevity once more in both questions and answers. Miles Briggs.
Thank you, Convener. I'll try my best. Can the Cabinet Secretary confirm that no one today is now being discharged from hospital who would have a positive test for COVID-19?
Cabinet Secretary.
What I can confirm is that no one should be discharged from a hospital who has a positive test for COVID-19 in any respect, actually. If they are in hospital and they've tested positive for COVID-19, then they should remain there and be treated for that virus.
Miles Briggs.
On reflection, Cabinet Secretary, looking back over this whole pandemic and the government's actions and the uncertainty about the spread of the virus, do you think it was appropriate at the time to push for such levels of delayed discharge and for you to purchase the care home beds that you did?
Cabinet Secretary.
I think it was entirely appropriate to ensure that where an individual, regardless of their age, was clinically fit to be discharged from hospital. In other words, they no longer required the care and the treatment that a hospital setting only could provide, then it was correct in the circumstances where we reasonably anticipated, based on the evidence that we had and the judgment we made about that, that the continuing to stay in a hospital setting, which was gearing up to receive large numbers of COVID cases, was not the safest place for someone clinically fit to leave hospital to remain. I think that was a reasonable judgment to make. At that point, on the basis of the information, the evidence, the knowledge that we had and the judgments that we took on the basis of that, I think it was right that we gave the guidance that we did to care homes. We worked on the presumption that we did in terms of their level of infection prevention and control. And we then supplemented all of that with support and PPE and so on. And of course, as I've said, the guidance that we issued and have continued to work to as it has been updated complies with World Health Organization guidance. So I think at the time we took all the steps that we could reasonably have been expected to take, as always with these matters, as knowledge of the virus, how it is transmitted, how it behaves, and the practicalities of dealing with it in a care home setting or elsewhere develops, then we will take different judgments and different views, as indeed we have done. And in terms of using resources, what we were aiming to do was to say to all of those charged with providing social care, be they local authorities, care home providers in whatever sector they're in, you need to do what you need to do in order to prepare and support your residents against this pandemic. And if that requires additional resource, government will provide that for you. I think that is the right decision for a government to take. Resource questions should not stand in the way of those organisations or individuals making the provision that we were asking them to make and that they knew they required to make.
And a final brief question from Miles Briggs.
Thank you, Convener. And the Cabinet Secretary has outlined that the April discharge figure for 2020 was fewer people than in terms of the 2019 April figure. Now, we know that March was a record level of delayed discharge patients, which were sent to care homes. Can I just ask, Is that an acknowledgement of the concern of patients actually contracting COVID-19 in a care home setting? And can she also outline how many families have tried to prevent or veto their loved ones moving from hospitals to a care home setting?
Cabinet Secretary.
So that last piece of Mr. Briggs' question is not information that I would have. And if I did, it would be entirely anecdotal, but I have not even got anecdotal information. Of course, if Mr. Briggs has that information, I'd be very happy to receive it and to consider it in a proper way. In terms of his comment about the two figures, the March figure and the April figure, I think to be clear, the March figure would be high because we were dealing with a backlog of delayed discharge, and I'm sure Mr. Briggs and indeed Mr. Stewart and other colleagues will recall the many feisty debates we have had in committee and in chamber about the levels of delayed discharge and the demand that government acted in order to reduce those. So that would be why we were dealing with a historic number in March, and you would see the reduction that you did see in all of the circumstances with all of the guidance and the precautionary steps that I've described. April, of course, will reflect that the start of April was clearly lower than the start of March, but also in terms of throughput in our hospitals for non-COVID related matters. As we know, we had the debate this week in the chamber on restarting the NHS. The numbers of other health care procedures undertaken in a hospital setting has been reduced in order to ensure that the health service could cope with the demand of COVID, and we are now in a position where we can gently and safely begin to restart those measures.
Thank you very much. I now call Emma Harper.
Thank you, Convener. Good morning, Cabinet Secretary. I have just a couple of questions about the Care Inspectorate, which you referred to already, but I just wanted to bring up a point that you made earlier when you said that the language of care homes is used as a care home industry. And I read in an article about a large care home provider that used the language that said there had been an increase in annual sales. And I was a bit shocked at that language because it's very businessy, when personally we should be thinking about care homes as homes for our older people. So it was just interesting that the language of industry was something that has been referred to. But I will ask my questions. The most recent emergency legislation increases the ability of Scottish ministers to intervene in care homes if necessary through the Care Inspectorate. So I'm interested to know, Cabinet Secretary, how has the Care Inspectorate been able to continue making the inspections? I've read about digital investigations. I would just be interested to hear your comments around that.
Cabinet Secretary.
So the Care Inspectorate has been undertaking on-site inspections. As I think I said earlier, from memory, I will correct this if I'm wrong, 27 on-site inspections to 19 locations. That reflects a situation where the Care Inspectorate believes that there are important improvements that need to be made from their first inspection. They set that out very clearly for the provider, and they will go back in a relatively short space of time to inspect whether or not those improvements have been made. The Care Inspectorate also, though, are in weekly contact with all care homes in Scotland and daily contact with some. They make that judgment themselves about what's daily, what's weekly, what's on site. They will work from information that they have about the number of infections, for example, that they are notified of, the number of cases they are notified of, but they also work from their previous inspection reports in terms of their assessment of any particular care home. So they determine all of that. They have a plan that they follow week by week on which care homes they intend to visit and inspect. So it is a mix for the Care Inspectorate between on-site visits, properly PPE'd and so on, and both digital and telephone.
Emma Harper.
Thank you. Are the Care Inspectorate's powers in the more normal times adequate in order to ensure that care homes are safe and provide high quality care?
Cabinet Secretary.
So we've touched on this before. Certainly the Care Inspectorate have a very important power, which is the one that they are exercising now in terms of their application to court for a provider of one care home to be deregistered. That is a serious and important power that they have. It is for the court to decide, and that is how it is set out, that it is a court decision so that the court can hear from all parties and take a view. The Care Inspectorate is thoughtful, as am I, about whether or not we look to see if there are more powers that they should have. They are in active discussion with the Healthcare Inspectorate in Scotland around expertise on infection prevention and control, and some of those on-site inspections involve his in that for their particular area of expertise. So it may be that the Care Inspectorate also consider that there are areas that they would like to strengthen in terms of the inspections in normal course that they undertake, and perhaps the powers that they then have or the procedures that they then use. We touched on that, the Care Inspectorate and I, very briefly last week when I spoke to the Chair of the Care Inspectorate and the Chief Executive and their colleagues, and I'm sure we will return to that. But right now, they, as they should be, are focused on the immediate situation and what they need to do to ensure the safety of residents and staff.
Emma Harper.
Thank you. I have just a final question. We know that health and social care partnerships, many of them are working really well with the NHS and together, and the Care Inspectorate and everybody working really well in order to provide good support across the care sector. So, and you mentioned streamlining earlier as far as reporting and engagement. So what kind of streamlining of reporting is already in place so that care homes don't duplicate any effort in reporting to various agencies? Are we able to make it more streamlined and seamless as we go forward?
Cabinet Secretary.
So I certainly think in reporting in this sector, as indeed in the health sector, there is certainly room to streamline the reporting. And in creating that room by streamlining reporting, we also give ourselves room to gather more of the data that is actually needed in terms of understanding everything that is going on in health and social care sectors and making that information public. And I think over the course of this pandemic, we have taken a number of steps in order to secure data that we can then be quality assured and we can be confident is robust in order to publish it. And as you know, we publish a great deal of data now, will, I'm sure, publish more in the future and have committed indeed to doing that. So we will have a conversation with the Care Inspectorate and with Scottish Care in terms of the reporting that is required from the care home sector, where there are improvements that can be made, but still provide the level of information that is needed both by the Care Inspectorate, but also importantly by relatives and residents. And I'm mindful there of the new measures. I did discuss this with the Care Inspectorate last week. The information that is available as a matter of course now in our hospital settings about infection levels, about falls, about a number of other important indicators that matter to patients and relatives. And I think we could look to duplicate that in an appropriate way in the care home setting, but we need to have that conversation to ensure that that is the right thing to do.
Thank you very much. Cabinet Secretary, just a brief question of fact. We know that in relation to the home farm care home in Skye that the Care Inspectorate carried out inspections in November and in January. Is it the case that they also carried out an unannounced inspection of home farm care home during lockdown?
Yes, it is. I believe that they may have carried out 2 unannounced inspections, but I can't be absolutely certain of that. Certainly one, and then of course they have taken made the judgment and taken the decisions they have taken, and it now awaits a court decision.
Thank you very much. I now call Alex Cole-Hamilton.
Thank you very much, Convener, and good morning, Cabinet Secretary. Initially, my questions follow up from Miles Briggs on testing. Cabinet Secretary, on January 30th, the New England Journal of Medicine cited the case of a Chinese woman who'd infected 8 people in Germany before becoming symptomatic. All told, there were a further 7 global alerts about patients passing on the disease before the onset of symptoms during February and March. Cabinet Secretary, the international health community was screaming about asymptomatic transmission, yet your government accelerated the decant of 1,300 patients from hospitals where you couldn't understand the spread of infection into care homes without a COVID test. Why did your government ignore those international alerts, and who was ultimately responsible for the decision to decant so many patients into care homes whose COVID status was unknown?
Cabinet Secretary.
So I want to make a number of points in response to Mr. Cole-Hamilton. The first of those is that I would not personally use the word decant. I think people were moving from a hospital setting to what I would anticipate is a homely setting, just as they moved, many of them, the majority of them, to their own home. And we've already rehearsed all the factors and the reasons around that, and indeed noted that at the time there was cross-party support, I think it would be fair to say, for that approach by government. In terms of international alerts, health alerts, we've said that there was and remains dispute in the scientific and health community about asymptomatic transmission. And if we look at, for example, the World Health Organization's daily COVID report on the 2nd of April, it says there are few reports of laboratory confirmed cases who are truly asymptomatic. And to date, there has been no documented asymptomatic transmission. So there's a lot of discussion and debate around this. What we expected, and I think it was reasonable for us to expect, was that our care homes were operating to that manual of infection prevention and control, as they should have been doing for all other infections, including flu. We set out the guidance on the 13th of March that was very clear about the mutual clinical risk assessment before anyone was discharged from hospital to a care home setting, and all the steps that we required the care home to undertake. Testing is, of course, important, but what a test tells you is that you are positive on the day that the sample was taken. Isolation for 14 days, as we required at 7 days and 14 days, proper infection prevention and control measures, the correct use of PPE, all of those are the steps that are required to prevent infection spreading. So one on their own will not do that for you. And of course, as we know, whilst the PCR test is very robust in detecting the presence of the virus when someone is symptomatic, it is less robust in detecting the presence of the virus when someone is asymptomatic. And there is a difference between being infected and infectious. A difference that work continues to go on to try and understand exactly what that difference is and whether or not it is of a sufficient margin that we should pay attention to it in terms of our guidance and advice or not.
Alice Colehampton.
Thank you for that answer, Cabinet Secretary. You've lent a couple of times on the suggestion that these issues had cross-party support at the time in the foothills of the crisis. That may be true, but we didn't have the wealth of scientific advice that you were privy to. We were only given what was filtrated and had been decided upon, and obviously we were given scientific evidence to back that up. Can I also remind you, press you to answer my question about who was ultimately responsible for the decision to move patients? But before I get to that, in those months of high infection, you already said that government policy remained to test only those in care homes who exhibited symptoms, and you maintained it was largely futile to test those who did not seem unwell. That's a point you've largely reiterated in that answer. But we now know that the PCR test does readily pick up COVID in asymptomatic patients. Indeed, we learned yesterday that 45 members of staff at Renaissance Care tested positive despite not having any COVID symptoms. So when the decision was taken not to test asymptomatic patients before their transfer to care homes, what empirical scientific evidence was offered to you or your advisors that the PCR test was ineffective?
Call the Cabinet Secretary, and then I will move on to Sandra White. Cabinet Secretary.
So to answer the last part of your previous question about who is responsible, I am responsible. I don't think there is any doubt about that, and I would never cavil against that. Of course, these decisions sit at my door, and I have done my very best to explain them. In terms of the PCR test for asymptomatic individuals, I don't believe I have ever said it was of no value. What has been said is that the degree to which its value was considered appropriate has changed over time, and we know that it is less robust in detecting the presence of the virus and whether or not that presence is there from someone who has already had the virus and there is a degree of viral load left in what is being detected, or whether they are pre-symptomatic of having about to develop the virus. And I think from memory, although I'll be happy to provide this for the convener later, from the Chief Medical Officer, his point about the PCR test in symptomatic individuals is 93% accurate in terms of detecting the virus and 100% accurate in terms of detecting this particular coronavirus. In asymptomatic, the percentage is significantly lower, round about the 80s from memory. But again, if that is not absolutely accurate, we will let you know. In terms of the information and the evidence, I have quoted some from World Health Organization. There is other, and it develops over time in terms of what the World Health Organization is saying about testing of asymptomatic individuals from that quote that I gave on the 2nd of April through until later, where there is more evidence pointing on balance to the value of testing individuals when they have no symptoms. And of course, that is what has taken us to the decision to test all care home workers, regardless of whether they work in a care home that has an active case or not.
Thank you very much. And I call our final member, Sandra White.
Thank you very much, Convener, and good morning, Cabinet Secretary. I want to touch, before I go to my question, a question which has been bothering me and it hasn't been raised by anyone else so far. Could the Cabinet Secretary say, or perhaps agree with me, but would it be fair to say that prevention failings with quality infection prevention and control in some care homes have led to cases of COVID?
Cabinet Secretary.
I would hesitate to be absolutist about that in my response. I think it is a reasonable conclusion to come to, but I think you would need to look care home by care home at how a case which first was a case first identified as quickly as possible. What were the steps that were then taken? Was the guidance from the 13th of March, 26th of March and subsequent being followed? What were the levels of PPE? How confident were staff in their training to use that PPE, both putting it on and taking it off, to key points in the use of PPE? Did they have the right PPE? And all those other steps before it would be reasonable to give an absolute yes or no answer to that. And of course, those are the areas that need to be looked at. And those are the areas that are currently subject to the Care Inspectorate's both telephone, digital and on-site inspections.
Thank you for that, Cabinet Secretary. Perhaps this will feed into my actual question, which is about social care review. Now, I mean, you did mention yourself, I think it was in the 24th of May, that care homes, very mixed economy, private, not-for-profit, etc. And the question was, is it fit for purpose? Now, this committee was going to do an inquiry into care homes, but unfortunately, hopefully we'll do it, when the time is right in that respect, when we have time. But I know that the Scottish Government's Adult Social Care Reform Programme is going ahead. So I just wonder if the Cabinet Secretary could perhaps give us more details on the plans of that, maybe the timings for it, and is this an additional review, and will this perhaps look at what was touched on earlier by George Adams, perhaps maybe a national care service?
Cabinet Secretary.
So Ms White is absolutely right. Before coronavirus 19, we had begun a review of adult social care, looking at the sustainability of the sector with a number of particular work streams. Under that clearly was paused in order to divert resources, people and other resources towards what we needed to do and still need to do to deal with coronavirus 19. How that will progress, I will need to consider. It's certainly the case that the learning from the pandemic, and particularly in the care home and social care setting, needs to be factored in to how that review continues. But whether or not that review in and of itself becomes subsumed into a wider review on the funding, the regulation, the provision of social care, including care homes, is not a decision that has yet been taken, but it is certainly in the mix. And as you say, towards 24th, I think, as you said, of April, I did make it clear that in my view, it was entirely right and proper to have a wider look at this provision of social care, and including care homes, and that would involve looking at the funding of it, the regulation of it, the provision of it, and what together as a government, but also the population of Scotland and of course colleagues in other parties, think should be the landscape in terms of this as we go forward. So we will give some thought to how the reform of adult social care that we had started and work had been undertaken in that, how that then is progressed, or whether it feeds into that larger review that we're touching on now.
Thank you very much. Yeah, I don't have a further question, that's fine. It's just about timescales, but obviously with COVID-19 we can't tell at the moment. Thank you, Cabinet Secretary.
Okay, we just perhaps have a moment to squeeze in a very last and brief question from Miles Briggs.
Thank you, Convener. I just received a response from the Cabinet Secretary after I asked my questions with regards to adults with incapacity. So I just wondered if she could confirm from her response to me, is it 88 individuals who have been moved from hospital to care homes who are adults with incapacity?
Cabinet Secretary.
If that's what I said in my letter to you, Mr. Briggs, then that will be correct. Of course, the movement of individuals in the category of adults with incapacity is not a government decision. As I think I set out in that letter to you from memory, there is a significant and important piece of legislation, of course, that covers all of this, and a very important role for local mental health officers from the local authority, and indeed our courts and the Mental Welfare Commission in regulating and determining what is best to happen to individuals in those circumstances.
Thank you very much, and thank you very much to the Cabinet Secretary, to Fiona McQueen and to Donna Bell for your participation this morning, which is much appreciated. We have run a little later than we planned, but I think in the circumstances I am pleased that we've managed to get so many answers to so many questions. So thank you very much, Cabinet Secretary and colleagues, and we'll move on now to the second item on our agenda, which is consideration of one negative instrument, the Adults with Incapacity Ethics Committee Scotland Coronavirus Amendment Regulations 2020. Can I ask if any members have any comments on this instrument? If not, is the committee agreed to make no recommendations? That is agreed. Thank you very much. That concludes the public part of this morning's meeting. The next meeting of the committee will be on Tuesday, and details will be made public in the usual way. As previously agreed, we will now move into a private session. I suspend the meeting for 5 minutes, and we will resume just after 11:15. Thank you very much.